Alrighty, thanks so much, guys. And if anybody would be interested in knowing more about the picture there, I can show you the case presentation where Dr. Stark and I straightened out a bent intramedullary nail by bending a patient's leg over an oxygen tank. And we're so excited about it that we decided to reenact it afterwards. Thanks, Dr. Lee, so much for the great start here. I think really covered very well the current state of antibiotic therapy for orthopedic infections and the best way to treat these patients given the tools that are available to us right now. For my portion of the talk today, I'm going to discuss a little bit more why these things are so challenging, as well as how in the future we may be able to do better. And I'd like to start with no relevant disclosures. I'd like to start by framing this issue in terms that we're not used to in orthopedics, and that's mortality. And the outcomes for these patients obviously are severe, but they start getting into realms that we're not used to dealing in. Usually we are not dealing with life-threatening situations, but if you compare periprosthetic joint infections against aseptic revisions, you can see there a stark difference in survival rates. And if we plot some of our more serious orthopedic infections against various cancers, as you can see in the table on the left there, this is a very grave situation, and it exceeds the severity of the typical orthopedic problem that we normally deal with. Unfortunately, we're also not improving in the eradication of these infections. If you compare outcomes from the early 2000s to 2011 through 2016, we're essentially unchanged in our ability to eradicate an infection with either an IND or a two-stage exchange for a periprosthetic joint infection. So at least for me, whenever I'm counseling a patient before this type of surgery, I feel a little bit disingenuous when I say, yep, the bacteria gets stuck on the implant, so we got to take it out and kind of leave it there. And because there has to be more complexity to this, and the problem is so serious that I felt it warranted a deeper understanding of what exactly is going on and why this causes such a huge problem. So I hope that after the end of this talk today, we'll all leave with a deepened understanding of what a biofilm is, why they are able to beat us, and how we could one day beat them. So biofilms, unlike the substance being launched here at current NFL MVP leading candidate Russell Wilson, is not just a bunch of slime. There is an element of the slime. It's known as extracellular polymeric slime, but that's only a portion of what makes up a biofilm. It's only 15% microbial cells. There's an extracellular DNA net-like structure that holds everything together, as well as a variety of proteins. And the majority of these are either Staph epidermidis, Staph aureus, or Pseudomonas aeruginosa when we see them in our patients. Biofilm formation goes through a series of 4 steps. There's initial attachment, then formation of a microcolony, maturation through quorum sensing, and dispersal. The initial attachment is all driven by passive adsorption from hydrophobic, electrostatic, or van der Waals forces, which essentially means the bacteria just fall onto the implant. However, once they've gained a foothold, there is a much more active process involved in aggregating and layering the bacteria, which involves multiple different proteins. Bacteria then go through a process known as quorum sensing to mature and disperse the biofilm, basically sensing the local density of bacteria in the area, and then activating a set of genes known as the AGR genes, which confer virulence factors onto Staph aureus in particular. Interestingly, those AGR genes are also responsible for activating many of the more systemic toxins associated with other Staph aureus infections, such as scalded skin syndrome and toxic shock syndrome. So how fast do these biofilms form? Very fast. In fact, once they have gained a foothold on a surface, the process of running that through to a mature biofilm is essentially already underway. And the speed with which the bacteria are able to establish themselves and establish this biofilm has led to the term race for the surface that Catherine referenced during her talk as well. And that term comes from a seminal paper in Science in 1987 by Dr. Anthony Gristina, who was an orthopedic surgeon, who said that it is suggested that the fate of an available surface may be conceptualized as a race for the surface, which is a contest between tissue cell integration and bacterial adhesion to that same surface. And one really provocative study on this that kind of demonstrates how that race for the surface works is a basic science study where they took osteosarcoma cells, so very highly active cells, which were able to proliferate rapidly and analyze their ability to adhere to a metal surface in the presence of varying concentrations of bacteria. And as you can see there, when there's no staphylococci, they're able to robustly adhere and form a layer on that surface. But when there's low doses of staphylococci, it's more difficult for them. And in the presence of high doses of staphylococci, they're essentially not able to really start laying down a robust surface. So that's kind of how biofilms work and how they set themselves up in our bodies and on these orthopedic hardwares. But why are they so hard to eradicate once they have gotten a foothold? Why can't we eliminate them? The first reason is inadequacy of the host response. So neutrophils do migrate to the site and do kill biofilm on the surface, or bacteria on the surface of biofilm, but they don't migrate into it, and they're not able to use chemotaxic signals to migrate through the biofilm. And if you look at this time-lapse photography here, you can see how the neutrophils essentially sit on one spot on that biofilm and kill everything that's in their near vicinity, but then never move to find the bacteria in the other areas. And what this leads to is the neutrophils have one of two options. They can either stop the immune attack when they've eliminated all the local planktonic bacteria, or they can spill all of their enzymes in an attempt to kill the bacteria that they can detect but not reach. And that process is what leads to the osteolysis associated with periprosthetic joint infections because it's ineffective in killing the local bacteria, but it is effective in breaking down local host tissue. There's several other ways that bacteria within biofilms can evade the host immune system. One of those ways is metabolic activity differentials. So the bacteria on the outside of a biofilm are able to access all of the nutrients from the host and consume all of them, leaving none for the bacteria on the inside of the biofilm. And that leads the bacteria on the inside of the biofilm to become metabolically active in what's called a persister state, which is essentially a spore. Additionally, they can transfer plasmids within the biofilm community to proliferate antibiotic resistance. And Staph aureus in particular has several mechanisms for directly attacking the immune system. There's also multiple reservoirs of bacteria that remain after a surgical debridement, which can then reseed a reimplanted implant. So the first is, as we've been discussing, the biofilm attached to the implant itself. Second is free-floating biofilm, which is actually actively dispensed as a portion of the quorum sensing process. The third is abscess communities within host tissues. And the fourth is that, as Dr. Lee referenced, Staph aureus can actually live intracellularly. And the power of these reservoirs of bacteria to lead to future infections is really powerfully demonstrated by a case study that was published in the New England Journal of Medicine, where a 10-year-old girl was treated with what was called scalloping, essentially debridement, of femoral osteomyelitis in 1934, so pre-penicillin, and was successfully treated, lived her entire life without any issues, and then developed an abscess at age 85. And allelic sequencing of that abscess indicated that it was susceptible to all antibiotics, including penicillin, despite the fact that penicillin resistance had spread through the entire world in the 1950s. What this means is that that was not new Staph aureus in her thigh. It was Staph aureus which had been there since the age of 10 and had remained dormant for 75 years. And this really underscores the difficulty associated with ever truly eradicating these infections, because Staph aureus in particular has so many reservoirs that it can hide out in and remain metabolically inactive before reactivating itself. And finally, this was covered extensively by Dr. Lee, a few points for why local antibiotics don't work better. The first is that the minimal biofilm eradication concentration is often 10 to 100 times higher than the inhibitory concentration. As you can see here, this is a log scale, and the white lines are the minimal biofilm eradication concentration. So as we discussed earlier, you start running into major toxicity concerns when you start reaching these massive concentrations of antibiotics. And as she referenced as well, antibiotic cement has a poor elution profile where antibiotics are only released from the surface of the cement. So all of that to say, essentially, biofilms have the upper hand against us in this battle. And there's a lot of reasons why we struggle to treat them with surgery, with antibiotics, and with our local immune response. So the question then becomes, can we ever do better? And will we be doing better in the near future? And I think it would be useful to start by looking back at where we've been able to make advances in the past. And I found it really striking when researching this that there is a clinical practice guideline put out by the AAOS for the diagnosis and prevention of periprosthetic joint infections, but not for the treatment. And once one of these diagnoses is established in a patient, we are really relying on all of the old tools to treat them. And if you look at the advances that we've made, they have absolutely made a difference for patients and have increased definitely the convenience of this, as well as the proposed effectiveness of what we're doing. But we're essentially squeezing every last drop that we can out of the old tools, which are do a good surgery, get as much bacteria out as you can, take out the implant, and treat with antibiotics before putting the implant back in. So here's a few strategies that could potentially in the future lead to better outcomes for our patients. The first would be to clear more bacteria during surgery by identifying more bacteria during surgery. And one of the technologies which is in the pipeline is using fluorescently labeled vancomycin to target infections caused by gram-positive bacteria, and then use a fluorescence video camera to detect them. So what this would allow us to do is, after the conclusion of our debridement, turn on the camera and look for these fluorescent vancomycin molecules to tell us whether or not we did a good job. And this has later been validated in a cadaver study in a human ankle, where they put an ankle implant, excuse me, an ankle plate in with biofilm attached to it, and we're able to detect it with this fluorescent camera. Another option would be to modify implant surfaces to rig the race for the surface towards host integration with host immune cells and set us up for success in that arena. Catherine briefly mentioned silver as a possibility for this, and there is, in fact, decreased biofilm deposition on silver nanoparticle-coated titanium screws as compared to plain titanium screws. And based on this, there is a company in Europe very aptly named the Silver Bullet, which will sell you a silver-coated screw for your orthopedic fixation. And over the next year, hopefully we'll begin to see whether or not this actually makes a difference coming out of Europe, as this was just approved in January. Another idea that's been tossed around is chitosan. So if you think back to some of the early biology classes in college, chitin is the exoskeleton of crustaceans and insects. And chitosan can be harvested essentially from the shells of shrimp by acid washing them and then treating them with sodium hydroxide in order to form a more stable structure. And when this is coated on the outside of titanium, again, we see decreased biofilm deposition without an effect on osteoblast disposition on that surface. The final option would be more nanoengineering type of modalities, and one of these is called nanotubes. This takes advantage of the size differential between bacterial cells and human cells, because a bacterial cell that tries to stretch across these tiny pillars essentially becomes mechanically disrupted, because it's only stretching across a few of them and it sags in the middle and it disrupts the bacterial membrane. Human cell, conversely, which is a lot bigger, is able to stretch across a broad array of them and not become mechanically disrupted. And when these are combined with a super hydrophobic coating, we do see decreased biofilm deposition as compared to plain nanotube arrays. Another option is to increase local antibiotic concentrations through novel delivery devices, which could potentially reach that minimal biofilm eradication concentration. The first of those would be hydrogels. So these are cross-linked polymeric structures with high water content that allow water to diffuse in and out, potentially allowing for better elution curves than what we see with cement or calcium sulfate, as we were discussing during Dr. Lee's portion of the talk. And in a randomized controlled trial on closed fractures out of Europe, where they chose antibiotics at surgeon discretion and essentially treated any fracture with any fixation by just putting this gel on the outside of it, there was a decreased rate of surgical site infections. Now, the caveat here is that this study has a high fragility index, as there were no surgical site infections in that hydrogel group and only a few in the control group. However, this is currently available online, and I was not able to get a response from this company regarding whether or not I could buy this to use it in the United States. All of their literature online referenced addresses in Italy, so it seems like this is only available for use in Italy or the European Union right now. But it has level 1 evidence supporting it and is being put in humans throughout the world right now. One very cool improvement of this technology is with pulsed release. So a study out of the University of Washington showed that when they use a modification of this hydrogel matrix, they can contain the antibiotics within it until ultrasound is pulsed onto the hydrogel. And that increases the temperature, disrupts the methylene coating, allows water to diffuse in and leach out those antibiotics before rapidly reforming. And if you look at the elution curves down there in the graph on the bottom, you can see that it's essentially released rapidly when this ultrasound is applied and then goes back to having no background release. And what this would allow us to do is treat these infections when they arise by putting ultrasound on the outside of the patient's skin and not having to go in and depot local antibiotics. Another option would be with antibiotic sponges, and in this study they used chitosan, very similar to the implant surfers referenced earlier, in a goat model of severe proximal tibia open fractures, and we're able to show a decrease in bacteria at the site of that open fracture, even when negative pressure wound therapy was utilized with a wound vac. The final modality that we could potentially beat biofilms with would be disrupting them after they've formed. And there's a lot of really creative ideas for how we could do this. The first one that we'll discuss involves disrupting the quorum sensing process. And when mice are treated with, when rats are treated with a drug which blocks the quorum sensing process, we do see a dose-dependent reduction in the colony-forming units of MRSA in that animal model. Another is through the use of nanozymes. So a nanozyme is a nanomaterial with enzyme-like characteristics. It is not technically a protein. And in this one, they combined two, one of them to disrupt the extracellular DNA net of the biofilm, and the other to form free radicals similar to peroxide, which would then kill the exposed bacteria after they were leached out of the biofilm as it was broken down. I'll be honest, I mostly chose to include this one though, because in the scientific paper describing the mechanism of action of this, they chose to represent their enzyme as a dragon wrapped around a double-barreled shotgun, shooting 2 separate bullets to represent their 2 different nanozymes. Finally, another one that we will discuss is vaccination. So essentially triggering the immune system to recognize the biofilm components which it might otherwise not recognize. And when a quadrivalent vaccine against 4 different biofilm targets is combined with vancomycin in a rabbit osteomyelitis model, we do see impressive clearance as compared to vancomycin alone or compared to controls. The last one I'll talk about involves bacteriophages. So bacteriophages are viruses which infect bacteria. And in this study out of HSS, they harvested a special protein from a bacteriophage which had broad spectrum antibiotic activity, and used that during a debridement and implant retention model in a rat, and then also treated systemically afterwards with it. And they saw very impressive reductions in the colony-forming units of MRSA present in that model as compared to controls or vancomycin alone. And very interestingly, one of these licenses in the phase 3 of a clinical trial right now for bacteremia and endocarditis, which combined with these impressive results in this trial is very encouraging. So to sum all of that up, you've got a lot of really cool, fancy sounding stuff where you can show a basic science trial with a lot of green glowing bacteria in a control and not so much bacteria in the treatment arm, which seems great, but how are we as surgeons going to decide whether we're going to try these things? I think Dr. Faring's talk on evaluating new technology provides some really useful framework for making that decision. The first question to ask is, does it solve an existing problem? And I would just turn to the mortality slide at the beginning of this talk to say, absolutely, this is a huge problem. And so we should be open to new ideas and new technologies because we could clearly do better for our patients. The second and third kind of dovetail together, and does it improve clinical outcomes and is it cost effective? And I think this becomes a really big concern when you deal with things like implant surface modifications where you have to put it on every single implant, particularly because infection rates are low enough. If you think about a periprosthetic joint infection rate of 1 to 3%, the number needed to treat in order to show effectiveness of essentially modifying every single implant in order to prevent infections becomes very high. So it's going to take very highly powered randomized controlled trials in order to determine whether or not spraying ship shells on the outside of our primary implants is going to result in less infections. This is going to be easier to analyze when it comes to technologies where we're actually disrupting the biofilms, things like these hydrogels or lysins derived from bacteriophages, where we can take patients with really severe problems and analyze whether or not we're able to effectively eradicate these things. And if you don't believe me, here is a case study where exactly that was done. This was a patient in France with an absolute disaster of a clinical situation who needed flap coverage for an infected megaprostheses, and was treated during that surgery with bacteriophages loaded in a hydrogel, actually the exact hydrogel that we talked about earlier from the closed fracture study. And unfortunately, this patient had a myocardial infarction 5 days post-operatively, developed a massive hematoma at this site, and eventually went on to amputation. But the point is, these things have been put in human beings to treat orthopedic infections. And we're going to have to decide in the near future how we are going to integrate these things into our practice and when we're willing to take a shot on trying some of these new technologies in order to treat these terrible, terrible problems. So in conclusion, biofilms are not just a bunch of slime. They have incredibly complexly regulated systems in order to both evade and attack our immune systems, and antibiotics necessary to eradicate them would result in large toxicity if administered systemically, and are difficult to obtain with our currently available antibiotic delivery tools. And numerous strategies are currently being studied to tip the scales in our favor in the battle against biofilms, and we'll need to be thoughtful in determining how to integrate those technologies into our practice. Here are my references, and I'd like to acknowledge several people who were instrumental in helping me put this together. Thank you very much for your assistance.
Thanks, Eric, and thanks, Catherine, for a great symposia. We're short on time, but I would open the floor for any of our experts that wanted to make a comment or ask a question.
Yeah, this is Tom Faring. Couple things. 5 years ago, I testified at the FDA for a drug delivery device on implants, and they consider those pharmaceuticals, and they are not enthusiastic about it, despite the potential of some of these things. But I want to ask Eric a question. Eric, after all your study on biofilms, when you have a patient who comes in after 10 years of functioning well with a joint replacement, and all of a sudden, you know, they've got a fever and swelling and redness, and you aspirate their joint, you're thinking it's an acute hematogenous infection. Is that an acute hematogenous infection, or what do you think's going on there? Or is that a biofilm problem?
I think the literature on this indicates that most of the time, unless we've got a really clear source of an acute hematogenous infection, it's probably from the surgery itself. And, I've seen some people where, they are acutely bacteremic with something else at that time. In the absence of an actual ongoing bacteremic infection, I think it's probably from our surgeries. And Dr. Karanarka had a really interesting anecdote that I think kind of drove this point home for me, which was he's had several patients who developed hepatitis C and then rapidly afterwards developed a infection at one of their surgical sites, which to me says that bacteria was always there. It was in a low enough concentration that the immune system was able to keep it at bay. And then when the immune system took a hit, it was able to flare up and kind of rear its ugly head at that point.
Yeah, I agree with you. I think acute hematogenous infection is exceedingly rare, and it's probably just as you surmised, that this is biofilm, planktonic release from the biofilm dome opening up and causing a problem. Great job, Eric.
Eric, I'll just make a plug along Tom Faring's same lines. I think, I was looking at all your technology that you were talking about and chuckling when you said it was only available in Italy, and that's exactly right. There's all these wonderful tools, but how much the FDA handcuffs us with antibiotic delivery devices, unless, if you look at the number of new antibiotic classes that have been developed over the past 30 years, it's extremely minimal, right? Companies realize that they have a better chance of a psoriatic drug that they can put a commercial that we see every 10 seconds on TV rather than developing a new class of antibiotics and having to go through the FDA. And I will just put a plug for a workshop that the FDA is doing in about 3 weeks. I know Mike Bossie's on the faculty giving a talk, and it's it's free. So you can go on the FDA website and register. And the main focus of the half-day seminar is going to be on drug delivery devices and future technologies. So hopefully they're starting to open their eyes up about this and develop pathways that will allow for quicker approval processes of some of these things that you outlined really nicely in your talk.
Yeah, cost is such an important factor now too, and that's going to weigh into it and make it even more challenging.
Yeah, I really think phase therapy, Eric, you touched on, is huge. There's been some really great case reports in the orthopedic literature on phase therapy. Jesse Otero and I looked into it a little bit here, and there's really nobody here that's doing phase therapy for any infectious diseases, cystic fibrosis, anything along those lines. So it may give us a platform to be able to start to look at this, de novo here at Atrium, some of the basic science work and dovetail it into PKI.
Yeah. Dr. Hsu, did you have a final comment for us?
I did. I was going to give a quick plug for
think you're on mute. I think we're having audio difficulties with Dr. Shu.
How about now? Can you hear me?
Yeah, we can hear you.
I was going to give a quick plug for Bailey Fearing and our translational basic science work. We're collaborating with UCLA, which is Nick Bernthal, that showed the glowing mice and the vancomycin labeling, as well as ISR, which has done a lot of that locally applied chitosan work, as well as the biofilm dispersal stuff. So I think in collaboration with our lab here, and we're starting to work with some of our total joint colleagues and other people as well, I think we're going to actually be well positioned to help translate some of this work clinically.
Yeah. Well, thanks for bringing that up. Yeah, Bailey's got a full lab now that's going to be devoted to pretty much infection on the molecular biology side, working closely with Joe and his trauma colleagues, and also with Jesse and our hip and knee center. So excited about that. Well, thanks everybody for tuning in. Great session, and we'll look forward to seeing you next week.